This is the latest update on the treatment plan for my heart failure. From the last video, you'll recall I have a couple leaks, one about 5 o'clock and one from about 7 to 9 along the border between the mechanical ring and the scar tissue around it. So the next question is, can they do anything about this? Over the past couple weeks, I've had a couple more doctor appointments, and what I learned is that next Tuesday, I'll be going in and they're going to seal the bigger of the two leaks. This will be a catheter procedure again, where they go in through the groin and up through the femoral to access the heart. Since I have what we call a paravalvular leak, they're going to be doing a paravalvular leak closure process. The closure device isn't exactly like the double-headed umbrella that they used for my PFO closure. It's going to be similar. One of the main differences is that it appears that it has more of a, instead of, if you look at it this way, these umbrellas are perfectly round, because when it was sealing the upper septum, the PFO closure, it could be round. This device is similar, except the plug is more rectangular in cross section instead of being just a circle. And the reason for that, it's a good thing, is because if you imagine putting a circle around here to fill that and seal that leak, the umbrella would be intruding into the area where the valve is trying to let blood flow through. So by not having a round profile and having more of a rectangular profile, the purpose for that is to be able to plug the hole while not impacting the function and flow of the valve. Of course, they tell you it could be a couple days in the hospital. I'd be very surprised if I'm not out of there that night. I'm going in at like 5:30 in the morning. They have to do another TEE to make sure that, you know, let's say there's another leak popped open up here or something like that. They just want a very good picture of what it's like right that day before they go in to do this. Totally understand. Since it's going to be going through the femoral, I would expect that I get some kind of an angio seal or angio plug, whatever they call it, so that I can go home that night. There's nothing to do with ablation that would cause rhythm issues to require me to stay overnight. So again, for all practical purposes, I do expect to be home that night. It's fairly low risk, very similar to what I had with the PFO closure, so don't really expect much for issues. My breathing capacity has improved quite a bit in the last month because I've been eating less, operating in a calorie deficit. I've been losing quite a bit of weight, and that makes a huge difference for the breathing. Just with the heart being so marginal, eating too much, weighing too much really taxes it. So I feel better already, not great, but improving. When I had the PFO closure a few years ago, the breathing capacity was a huge improvement after getting that closure device. So based on that past personal experience, I am cautiously optimistic that after getting this seal, I will be able to tell that my breathing's improved even a little bit more than what I've already done with the diet and exercise. Now let's say we get through this procedure, there will have to be some kind of a follow-up to see what the ejection fraction becomes. The last echo that I remember showed that I was at a 30 to 35% ejection fraction, and just as a reminder, anything 41% or less is what we call cardiomyopathy, which is just a fancy word for heart failure. So at some degree of it, right? And then your 50 to 70% is what we call normal. I'm obviously way below that at this point. So they fix that. We'll do another echo in a month, 2 months, 3 months, whatever, to see what the ejection fraction is after all this is kind of settled in. Now this plug won't be sealed 100% right on day one. If you think back to the old PFO closure video I did years ago, this material for these plugs and seals, they're kind of like a strainer. They're a mesh. They have little holes in them, lattice. And the idea is that the epithelial cells inside the heart then grow over to sort of seal all those little holes in there. So it's just a structure to help the epithelial cells collect and and seal it somewhat naturally over the plug or seal device. Now, as your ejection fraction falls, that's bad because that basically means your breathing capacity is getting worse, your heart function is getting worse, your circulation is getting worse, and the pressure in your lungs is getting higher, which is bad because eventually what happens is that number gets so low it can't evacuate the fluid out of your lungs, and that's bad. When a patient first goes in for a low ejection fraction, there's three basic causes that they identify. It can be a heart attack. In other words, you've had a heart attack, you've got damage to the tissue of the heart and it's failing to do its job. You can have a valve issue, such as a leak or a stenosis, which is my problem right now. Or you can have viral. So let's say that you were sick. Some of these after effects of earlier strains of COVID, I've heard of people having a normally healthy that get a very reduced ejection fraction as a result of that as well. But there's three basic items that they can identify as causes for why you would have a low ejection fraction. The first thing they want to do is fix the root problem, right? So if you've had a heart attack, they want to make sure that your arteries are now open, do the bypass, whatever they need to do, and eliminate the root problem. And you still may have some damage to your tissue, but until you fix the root problem, the tissue doesn't have any chance of recovering, it just gets worse. Same with the valve. They're going to go in and fix this leak, and then ideally the hope is that the ejection fraction would improve a little bit, because with this big leak, the heart is being inefficiently run, which means it's weakening the heart even more. It becomes a compounding problem, right? Because the heart's like, well, I got a leak, I got to work harder. Well, the harder it works, the worse it gets, and the more enlarged it gets, which causes even more problems. Because if you have a chamber of the heart and the tissue around it is increasing, it's enlarging, well, then your capacity inside the chamber is getting smaller, which means that it has to go faster. It ramps up going faster to account for the smaller capacity of the chamber, which makes it larger, and this whole thing just snowballs on itself until it fails. And the third one being viral, you obviously want to address the infection, get that taken care of. So you address the root problem, and then you say, now where's my ejection fraction? At some point you get down to what they call menus. And with the menus, you have 3 to 4 different pharmaceutical options that they would give you for low ejection fraction. Now, if you remember from an earlier video, I mentioned Pharmaceutical was something that was brought up a couple years ago. That conversation with that doctor, I was told that it's not going to improve my ejection fraction, but it can help with mortality. In other words, less likely to die. But in my mind at the time, I thought, well, I'm not really interested in something that just makes me live longer feeling awful. I want to have maximum quality of life. And I obviously want to avoid taking whatever drugs I can as long as I can. My understanding now, after these last couple doctor appointments, is that there are these 3 to 4 different drugs that they could prescribe as a cocktail for low ejection fraction. So the first thing is fix the root problem, see where the ejection fraction is. If it's still pretty bad, depending on what pretty bad is, right, then they may go to this cocktail to say, maybe it doesn't, let's say if this is my ejection fraction, maybe after all this I'm back up to 40, let's say. So if I'm at 40, which would be great, then maybe it won't make it go up anymore, right? But maybe those drugs, instead of it tanking like this, maybe it goes down a little bit slower and reduces the mortality, keeps some of these drop-off possibilities out of there. And so even though I don't improve my quality of life now, it may give me more quality of life over the upcoming period of time by not allowing the ejection fraction to drop as fast, as well as potentially keeping me alive longer. Now, as the EF worsens even more, then you eventually get to a point where you may have to look at things like pacemaker. Generally, that's because your rhythm is also struggling because the heart is so bad at that point. There are pacemakers that are one-sided, which are easier to install. However, If you get to the point where you're bad enough, then at that point, they may put in an implantable cardioverter defibrillator, or ICD. Now the ICD they have, not only will, a defibrillator works on the fact that if your heart stops, it applies electrical current to kickstart your heart, for lack of a better way of saying it. So it prevents death, because otherwise if your heart stops, it's pretty unlikely you're gonna have a 911 call and anybody show up and actually be able to save you. It's probably done. So this thing would be an onboard, in the chest, implantable device that would kickstart your heart if it stopped. The other thing it has on board is not just a pacemaker, but a double-headed pacemaker. And there's a signal in the EKG somewhere where there's some gap, and I don't remember exactly what they call that particular gap in the wave, but you have to have a gap in here bad enough, which he looked at my EKG and he said, yep, yours is probably bad enough you could get it. And that would allow you to get the that would allow me to get the ICD with the double-headed pacemaker. And in doing that, by applying that pace-keeping current to both sides of the heart, it more closely mimics nature. But again, you have to determine that my EKG is bad enough, which it is first, before they would approve that. And by they, I mean insurance, basically. Like I said, the procedure is next Tuesday. Come out of that, see how the breathing is, see if it's better. Probably follow up, I don't know if it's 1, 2, or 3 months it'll be on the next echo to see, now that that's fixed, give it some healthy living, some relaxation, see if I can get that ejection fraction up a little bit more. And once they do that, then we'll have to evaluate, is it time to look at the menus, or is that going to be okay that I can enjoy a quality of life for some period before resorting to pharmaceutical plans? In the few months waiting for that next echo, now I can start doing some of these trips I've been kind of putting off, try to get back up north to Iowa to see family and friends and the college buddies up there. Maybe another motorcycle trip to Colorado while I still can. If the breathing is good enough, may even do a surf trip to San Diego. So just kind of have to see what happens. And of course, Florida will eventually be on my list too. If you haven't done so, please click the link below to subscribe to the channel. Hit the little bell for notifications. Check out the YCC merch store, see if there's anything you like. And let's live for today.